Okay, before we begin, reminders to all attendees of the 12th Biennial Symposium. You may type in your questions regarding the lecture in the chat box, and the speaker lecture can answer them in the chat box, or you may personally communicate with the speakers by sending them message to our email address. Kindly answer our evaluation form after the last speaker of the session. The link will be seen in the chat box. And for our third lecture this afternoon, now that we have already discussed basically the lung physics and pneumology, and we have also gathered some information with regards to the point of care using the ultrasound uh, in matters of the lungs. The next lecture for this afternoon is all about the heart. Our third speaker for this afternoon had his fellowship training in cardiology at the UPPGH and subspecialty training in echocardiography at the Philippine Heart Center, a fellow of the Philippine College of Physicians, Philippine Heart Association, Vice President of the Philippine Society of Echocardiography, and Fellow of American Society of Echocardiologists. He is currently the Executive Director and Concurrent Cardiology Chief, Cardiovascular Institute at Angeles University Foundation Medical Center, and the Section Head and Director for Training of Adult Echocardiography, Division of Cardiovascular Medicine at UPPGH. Likewise, he is also a clinical associate professor of UP College. Ladies and gentlemen, it's our honor to welcome this our third speaker, Dr. Jose Donato A. Magno, to give us a lecture on the card focus point of care.
Greetings to my colleagues from pulmonology and critical care medicine, and thank you for this invitation to talk about cardiac point of care ultrasound. I'm Dr. Magno, an internist and an imaging specialist by inclination. To help me talk about this very important topic, I have outlined 3 simple learning objectives. First, we will focus on the current dilemmas in cardiac imaging today and try to zero in on the imaging issues that matter to both the patient and the clinician. Second, I will highlight the incremental benefit of portable technologies and those that are used for point of care imaging. And finally, I'll give my personal insights based on real-world experience on how we can incorporate cardiac focus in our clinical practice. Watch out for the 5 cardiac imaging issues that matter, the 5 benefits of handheld imaging, and finally, the 5 integration areas for cardiac focus. Let's talk about gaps and dilemmas. It is pretty obvious to everyone that the demand for cardiac imaging is steadily growing, and this creates a lot of imbalance because of the finite numbers of machines and human resources. Not to mention that these resources are maldistributed in an archipelago such as the Philippines. Because of this, there are a lot of constraints that are placed on the healthcare system, and this necessarily affects timelines of cardiac imaging. Just to mention some local data, back in 2015, we had the first Philippine Echo Survey, which demonstrates that majority of our experts in echocardiography are concentrated in the metropolis. Add to that the fact that there is actually mushrooming of cardiac imaging laboratories across the country, and the numbers of experts cannot keep up with the numbers of cardiac imaging laboratories. This also consequently leads to variability in terms of echo study reports and quality. And speaking of quality, one important aspect of echocardiography that needs to be emphasized is correctness of measurements. Problems in measurements will obviously lead to incorrect assumptions and conclusions, and this can sincerely affect end users' decisions and clinical behavior. Because of that, there are some societies, particularly the Philippine Society of Echocardiography, that really lobbies for harmonization and standardization of techniques. So what are the heart issues that are commonly encountered in our real-world practice? You might encounter some of these patients who will ask the following questions about strength of heart function, the size of the heart, the presence of possible murmurs, the presence of fluid around the heart, or even the possibility of inborn or congenital heart disease. And if you think about it, we can summarize it into 5 important matters. Matters on strength or systolic function, chamber size, regurgitation or stenosis, effusions and extra or intracardiac masses, and of course, shunts or intracardiac anomalies. So these are the 5 imaging issues that we can put the spotlight on when we talk about cardiac focus. Let's now talk about point of view in the incremental benefit of portable technology. We've realized across the decades how various technologies have shrunk in size. And this is essentially miniaturization of technology, which I feel basically is providing us with the capability for cardiac imaging, literally and figuratively, in the palm of our very hands. What are the incremental benefits of miniaturized technologies? Here are some that I can offer for you. Speed and safety. Of course, it is quite easy to grab that handheld machine to do point-of-care imaging, especially in critical areas. Portability. You can easily bring this machine to various areas of the hospital or the clinic. Accessibility. This will be actually an issue, of course, if certain areas will not have access to bigger console machines, such as the ones that we use for our standard echocardiograms. Compactness, you can easily fit this in the pocket of your clinical gown. And elegance, of course. It's easy to use this, and the images are quite nice to visualize. So here are the 5 benefits of handheld imaging. Now let's talk about focus. What exactly is point-of-care ultrasound? Roberto Lang and his colleagues from the American Society of Echo say that focus actually capitalizes on 2 important things: immediacy and the availability of this particular ultrasound machine at bedside. And this is quite important, essentially when you are triaging patients and when there are clinically urgent items that demand our quick and decisive action. Not to mention if there are some findings that you can miss out on because they are intermittent or fleeting. So it necessarily follows that cardiac focus will focus essentially on cardiac images or cardiac issues. As far as cardiac focus is concerned in terms of application, there are 2 general applications. The first is for generalized practice. This can concern general physicians, emergency physicians, primary care physicians, wherein cardiac focus is used to augment physical exam findings. Let's say you are at bedside and you picked up a murmur using your stethoscope. You can use this handheld technology to confirm the diagnosis or suspicion of a murmur in the patient, and you can add this to your physical exam finding report. On the other hand, there is what we call subspecialized practice, in which case cardiac focus now serves as a formal, limited echocardiogram, which is directed to answer a specific clinical question after, and I repeat, after clinical evaluation. How different is this from your standard transthoracic echocardiograms that we request at the in and outpatient clinics. The keyword here is limited, which means it is still more expansive than your UAPE, but it is requested after knowing specific items in your clinical evaluation. It is still a formal test, and it is required that those who will perform limited echocardiograms will have gained particular training and expertise or proficiency. As far as ultrasound augmented physical exam is concerned, we have realized that there are various protocols that we can call upon. And one of them is the CLUE protocol, or cardiovascular limited ultrasound evaluation. This is a pretty important protocol, well validated, a compilation of 6 easily learned, quick look ultrasound signs performed within a short period of time, as a matter of fact, anywhere from 2 to 3 minutes. And you can see that this focuses on some of the more urgent and important signs to look out for with respect to cardiac hemodynamics, and of course, a little bit on lung pathologies. Now, if you're wondering what are the cardiac conditions that we can pick up using cardiac focus, the successive images will be actual patients that I have been able to encounter in real-world practice, which will highlight the mnemonics screen. The first patient is a 40-year-old that I encountered at the intensive care unit. This patient was admitted for chest pain and was managed as acute coronary syndrome. You will notice, obviously, at the get-go, using a parasternal long axis view, that there is hypo or even akinesia of the anteroseptal segments of your left ventricle, in contradistinction to the hyperdynamic contractility of your inferolateral wall. This quick look already tells you a little bit about territorial involvement in MI. Let's look at the next patient. This patient was also evaluated for the suspicion of ischemia on ECG. And you will see in this short axis cuts of your left ventricle that there are segmental wall motion abnormalities already picked up using cardiac point of care ultrasound. You can also come up with a visual estimate of this patient's left ventricular ejection fraction. Now, how about chamber size? This is an elderly female that I encountered in a medical mission in our province. And this patient was complaining of occasional shortness of breath. This point of care ultrasound already demonstrated, obviously, a dominant right ventricle here and some possible hypokinetic segments in this particular ventricle. In this case, these patients have now to be referred for subspecialist evaluation for possible completion transthoracic echocardiography and other non-invasive investigations. In this case, maybe this patient might have an underlying lung pathology or maybe a pulmonary embolism for that matter. How about for regurgitations and stenosis? These images demonstrate on the left-hand side that there is very subtle diastolic doming of your anterior mitral leaflet, suggestive of a rheumatic pathology. When you apply color in this particular cardiac focus study, you will see evidence of regurgitation and even turbulence during diastole, suggestive of mitral stenosis. In this case, the next best step would be to refer for completion transthoracic echocardiography and Doppler studies to document gradients across that mitral valve. Let's look at the next example here. An elderly female, also in the community, complaining of shortness of breath. Even with these 2D echocardiograms, you will already demonstrate a lot of information. You will see an echogenic annulus here, indicative of calcification in the mitral valve. and also on a short axis cut of the aortic valve, demonstrating thickening of the cusps and even rolled up edges, all suggestive of some valvular pathology. This patient was suspected to have aortic stenosis and was eventually referred for full echocardiography. Another example of a patient with shortness of breath and evidence of turbulence across the aortic valve. Take note that we do not decisively label this patient to have the particular pathology because cardiac focus only intends to uncover anomalies that need to be confirmed on full studies. Now, for the next possible condition, let's look at this patient here, a 50-year-old male at the ICU complaining of shortness of breath. What are the clues on this cardiac focus? You will see here the pericardial territory, quite prominent, increased echogenicity, suggestive of thickening or possibly even calcification of your pericardium. And there is some suggestion as well of some pericardial effusion. On the right-hand side, you will see an apical four-chamber view of this patient. There is actually very subtle septal bounce, suggestive of ventricular interdependence. And when you see these signs, you might entertain the possibility of constrictive pericarditis. In this case, you need really a full study with Doppler interrogation to document signs of constrictive physiology. Moving on. This was a young female that I saw at the medical mission again, who was asymptomatic. But fortunately, because of this cardiac point of care ultrasound, I did a subcostal view on this patient to uncover what I believe is an intracardiac shunt, particularly an atrial septal defect. As you will see, the collar Doppler demonstrates flow from the left atrium to the right atrium. So an ASD was suspected in this patient, coupled with evidence of dilated right heart. This patient has to be referred for a full study to confirm the presence of the ASD and to assess its severity. So those are the real-world conditions that I have encountered in my practice as a cardiologist. Now let's talk about application in real-world practice and how to incorporate cardiac focus. As part of my work in the Philippine Society of Echocardiography, we were able to develop a point-of-care imaging template, which we used back in 2015 during our mission with the American Society of Echocardiography. This template is just one of many that you can use to guide your cardiac focus studies. Back in 2016, we collaborated with the American Society of Echocardiography. And as mentioned, these echo missions were very valuable for us in helping us screen patients for cardiac disease. At a community level, this was also obvious in my past experience in medical missions with the Philippine Heart Association Central Luzon chapter. We were able to do point-of-care imaging for patients in the community. Take note the 5 benefits of handheld imaging and how compact it was and how accessible it was and how portable this technology is that you can even bring it to the mountain provinces. Now back to practice in the metropolis, here are some of the indications for urgent cardiac imaging, and I will highlight them using an easy graphic here. These are the guidelines that we use at the Philippine General Hospital for urgent echocardiography for patients with suspected or confirmed COVID infection. Take note of the 6 conditions: patients with hemodynamic instability, those with chest pain syndromes, those with chest trauma, those with aortic syndromes, those with acute heart failure, and finally, those suspected to have acute valve dysfunction, such as acute severe mitral regurgitation. This serves as a guide for us to scrutinize all requests for echocardiography, making sure that they are all appropriate, indicated for acute conditions, and can be performed using an aim-oriented strategy. To add to that, the Philippine Society of Echocardiography released local guidelines on quality and safety at the height of the pandemic. This was a collaboration between the PHA and the PSE, calling on various leaders from different laboratories and training institutions in the country. This graphic shows you an algorithmic approach to echocardiography amidst the pandemic and how handheld imaging or cardiac focus can benefit patients during these times. As I highlight, these are some of the questions that we ask to determine whether to proceed with the full study or to perform point-of-care ultrasonography for these patients. On top of that, the algorithm from the PAC also provides guidance in terms of protection amidst COVID-19, giving guidance about leveling for personal protective equipment. Now, when we talk about how to perform the point-of-care ultrasound at bedside, here are some of the essential views for COVID scanning. Take note that this is pretty much streamlined, and it will limit the time of exposure of the sonographer or the physician at bedside, most especially if COVID-19 is suspected or confirmed. We recommend the following: a parasternal long axis view to document wall motion and even focus attention on important valves such as the aortic and mitral valve. The parasternal short axis view to also uncover wall motion abnormalities in different segments. The apical views focusing on various segments of the left ventricle as well as the right ventricle. And finally, a subcostal four-chamber view to uncover underlying shunts and to also give us a glimpse of your inferior vena cava for volume status estimation. So finally, what are the 5 areas for possible integration of handheld imaging or POCUS? I see them as plugging gaps in cardiac imaging using handheld ultrasound. The first is for guidance for procedures and clinical monitoring. If you will need ultrasound guidance for evacuation of pericardial effusions, this will be quite useful. Triaging at emergent and critical areas at the ER, especially for chest pain syndromes. Screening for select conditions in special populations, as what I mentioned. The possibility of using this for community cardiac imaging to screen important conditions. Streamlining of laboratory workflow, especially if you want to reduce unnecessary or inappropriate requests for full studies. Cardiac focus can help you triage and clear out these particular items. And finally, bridging for comprehensive study, knowing fully well that cardiac focus only gives us focused, targeted, and limited information, which needs to be confirmed with a full and formal transthoracic echocardiogram study. So as I end my session, I leave you with my key takeaway, which is echo. And what does echo do? It basically is evaluation of the cardiac status of patients to improve healthcare outcomes. So let's recap our session objectives. At the start, I highlighted 3 important things: point of order, point of view, and point of care. Remember the 5 cardiac imaging issues that matter: strength, chamber size, regurgitations or stenosis, effusions, extra or intracardiac masses, and intracardiac shunts. The benefits of handheld imaging and cardiac focus: speed and safety, portability, accessibility, compactness, and elegance. And finally, 5 areas wherein cardiac focus can plug in gaps: triaging, screening, streamlining, guidance, and bridging for a full study. Thank you very much for your attention, and Godspeed, everyone.
Thank you, Dr. Jose Donato, for that wonderful lecture. It's been enlightening for us. And in behalf of the Philippine Foundation for Lung Health Research and Development Incorporated, in cooperation with the Philippine Heart Center Division of Pulmonary and Critical Care Medicine, with deep appreciation, we would like to award the Certificate of Appreciation that reads the 12th Biennial Symposium, Exploring the New, Novel, Explicable Wonders in Pulmonology, given the 16th of September 2021 at Quezon City, Philippines. Signed by our Chair, Scientific Committee, Maria Paz B. Mateo, our overall Chair, Bernice Ong de la Cruz, Chairman for Scientific Committee, Johnny John R. Jimenez, Head Division of Pulmonary and Critical Care Medicine, Dr. Eileen E. Guzman Bonson, and of course, our current president for our Lung Foundation, Dr. Cesar Antonio. And we would like to invite all the participants to attend the Boehringer Ingelheim Dinner Symposium after the last session.